You're listening to another episode of Perfectly Imperfect. Hi, Val.
Hi, Dr. Houssock.
Welcome to the Perfectly Imperfect podcast.
Thank you for having me. I'm excited to be here.
So, what is it you say you do here at JEV?
Oh, everything I love. Let's start there. So, probably my main role that I do here is I am one of the operating room nurses. So, I get to check people in. I'm also the circulating nurse, so I'm in the operating room opening things when you guys need stuff. Making sure that the patient is safe. I also can help recover if I need to.
So you're a jack of all trades? Is that what you're saying?
I mean, I guess, yes. I'm not trying to toot my own horn.
Here's the thing about Val. Val refuses to just be good at one thing. Val likes to be good at everything. So Val is not only integral in our operating room, she does a lot of our kind of preoperative things, and then she also does injections. So you're going to see Val a lot on this podcast because she's got a ton of knowledge.
And I love the operating room. That's my home. Dr. Houssock has tried to, I wouldn't say kick me out, but like she's asked me like, all right, do you want to kind of branch off to like focusing on one thing? And I'm like, no, I don't. That's my home. That's what I'll be for the rest of my career for sure.
All right. So what are we going to talk about today?
So we're going to talk about one of my favorite surgeries, and that's a good old breast augmentation for the full name of it. Something we do very often here, and it's very fun. I love it.
So what we're going to do is Val's going to go through, she's going to kind of talk through kind of a question and answer. And that way people can learn from us. Sound good?
Let's do it. Dr. Houssock, how do you help determine the right implant size for a patient?
So I think there are two parts to that. So there's the part where people think about volume, which obviously is very important, but there's the whole other side that kind of gets forgotten when you see a bad augmentation, and that has to do with the patient's breast footprint. So every woman is born with a specific breast footprint. That breast footprint is measured out on the body. It's very particular to the patient's frame, and that is ultimately how you fit the best size implant. And I tell patients that I will take care of figuring out what that breast footprint is, and their job is to figure out their volume. So, and a volume can be any number. It really comes down to then fitting that volume into their breast footprint.
Have you noticed any trends in breast implant sizes lately?
So I think it depends on where you are, right? So like here in Maryland and kind of part of the Mid-Atlantic, we have pretty moderate patients, meaning that they're pretty conservative. They typically opt for a more conservative implant. I will say probably over the last few years, I've noticed a smaller implant size. Patients are really adamant about not looking like an implant patient. It's a very big deal to a lot of our patient population. So I would say, generally speaking, here we're seeing patients going more petite, but I also think that has to do with our ability to do that for them. Like we didn't always have those choices before. We have a lot of options. So, I say that, but on the same, breath, last week, 2 weeks ago, we had literally in one day an augmentation where Val and I put in the smallest implant that exists for the company that we use. And then we literally followed it by putting in the largest implant that they make. So I still think there's obviously a population for everything.
And that's the beauty of this industry is like we can accommodate so many different, type of footprints and, looks that they're going for. So yeah, that's awesome.
Yeah.
Do you think a breast augmentation can improve asymmetry?
Oh, definitely. They're probably some of my favorite breast cases. because there's a lot of fun in that, right? So if you have a patient, which is most patients who come in and do not have completely symmetric breasts, it's it's very easy to fix that in a lot of patients just by volume. Now, it doesn't work for everybody. There are still patients who require unilateral surgeries like a breast lift and whatnot that might still be necessary. But I've certainly done plenty of patients where just that little bit of asymmetry can be fixed with implant alone. And the way we typically do that is we tell the patient to size their smallest size, meaning whatever side they use that's the smallest, they want whatever they want to use on that side, and then we'll just match it on the other side. And we use sizers intraoperatively. So even, Val and I will sit them up and we can look at everything.
Dr. Houssock, what brand of implants do you prefer?
So we use the Allergan company called Natrel. My reason originally was because I had started working for this practice before I purchased it, and that is the company that the surgeon was using at the time. And then I got my hands on it, really loved it, but it's kind of evolved from that. I've definitely now, as I become a more mature surgeon, been able to kind of dive out and look at other um, particular, companies, and I still am tried and true with them. I find that they are. I have so many options. So when we talk about that breast footprint, it's not just about volume; it's about projection, it's about diameters, it's about cohesivity, where you you can decide how stiff that implant is, and I just feel like they have the best range for me. Um, in addition to that, we have very low problems with them, meaning that um, they have a very low profile for rupture. Patients seem to really love how they look in the body. There's not a lot of concerns with rippling. So for right now, I'm in, and it doesn't mean that I'm not always looking and monitoring what's going out in the world, and we're always going to offer what's best out there for our patients. But right this second, I really love Natrel.
I'm sure you get this question a lot during consults. Patients are always looking for that gummy bear implant.
Yeah, so like I don't even know. That's so at this point I feel like that's so antiquated, but at
Mm-hmm.
some point, maybe 10, 15 years ago now, somebody came up with that word gummy bear implant, and now it kind of stuck, and all it means is kind of the silicone that's inside. So the silicone inside the shell way back when these first started being made was more of a liquefied silicone. So it felt really jelly like and soft. But if the outer silicone shell ever ruptured or had a crack in it, that silicone was very liquidy. It kind of feels sticky. And so when a patient would have rupture, it was really difficult to clean that out. Not only that, it didn't really hold its shape very well. It kind of moved and maneuvered, and so patients would have rippling, even though it wasn't. It was still silicone, it still wouldn't keep that shape well. And so over time, it's just, everything evolves just like the iPhone. I always say the implants have evolved just like that. And now that gummy bear means that the gel is much more form creating. And not only that, if it does rupture, it kind of sticks together like if you were to split a gummy bear in half. It's not going to kind of liquefy out like a gusher. It's going to be more like a gummy bear. And that is for two reasons really great. One, if you happen to have a rupture, it's really going to hold its shape well, and it's not going to be extremely difficult for the surgeon to remove it. And when it's in the body, it holds a shape very nicely. So it looks like that soft, round breast that everyone's looking for. Um, so that's been around for a while. And I feel like now what we really play with on that is just how stiff it is. And some patients need a lot of stiffness and a lot of shape, and some patients don't need as much of it. So we can play with that a little bit for that, perfect look.
And that just shows how much technology is really advanced in aesthetics. With those implants back then, definitely, did not give that natural looking shape. And, we sometimes will see these ruptures that, these implants that are, gosh, 15, even sometimes 20 years old. And they're just, you can definitely tell that the structure of the implants have improved so much.
Yeah,
For
no
sure.
question. No question. It's cool for us because Val and I will take out these implants that are like 20 some years old, and it's, companies that don't even exist anymore. And I mean, it's pretty impressive. Some of them are completely intact and they look completely fine, and you wouldn't know any different. And some of them are crazy. But regardless, it's a inert type of product. So even when they're that old, generally speaking, patients do really well with them, even when they're 20 some years out.
Mm-hmm. And now I feel like, gosh, when was the last time you put a saline implant in?
It was in residency. So I haven't put one in. I always tell patients that they have that option here, but that I haven't put one in since I started practice. And I think they kind of get the hint. And it's not that saline still exists for a reason. It has its place. There are plenty of women walking around with saline implants because there was a decade where we couldn't use anything else but saline. And so there are still women who have them and they're doing great. They're still being placed by a lot of surgeons. My particular choice is not saline, and it just has to do with, how great and how wonderful I think silicone implants do for the patient, not only in their safety profile, but in how natural they look. And because of that, I just really opt for silicone. But, if a patient demanded a saline, I would still do it. It's not my favorite.
It's good that we still have the option if we needed to use it.
Yeah, absolutely. And I think one of the reasons why patients come in asking for it is they think it's quote more natural, meaning that it's water. So they somehow see it as a less concern of putting some kind of a foreign body into their body. But unfortunately, one of the statistics that I always educate on is that it doesn't matter whether it's saline or silicone. If you're worried about, for instance, breast implant illness, we see it in both populations. So you're not resistant to breast implant illness with a saline implant, mostly because a saline implant is surrounded by silicone. It's a silicone shell. And then there are downsides to saline in the sense that it doesn't have that as natural feel as that new, beautiful, cohesive gel that silicone has. And then there's the worst case scenario. If it ruptures, it's a water balloon. So
you just absorb it.
that thing ruptures and you wake up without a boob. So you have to kind of take the pros and cons with it.
Sure. Let's talk about incisions. So where is
I'm sorry, I'm taking a sip of my Dunkin' coffee. We aren't sponsored yet, but I just wanted to mention how much I like it. In case someone's listening and wants to sponsor us. No, we are not sponsored by Dunkin'.
We wouldn't hate it though.
Just saying.
We do survive on Dunkin'.
Yeah, we have no sponsors. So if you're listening to this podcast and you think that anything we say is sponsored, it is not. The labels that we're using are purely just by love. That's it.
Let's talk about incisions.
What about them?
Where are your breast augmentation incisions?
So all of my breast implant incisions are in the inframammary fold. So right underneath that breast crease where they're well hidden. I do not offer any other incisions. They exist. There were a few of them were really popular. I mean, not popular, but talked about a lot more, years ago. But one of them being the armpit, so the axilla, going through the axilla. Mm-hmm. The other incision that was really popular was around the nipple, and the argument on that one was that it healed really well and was well hidden, which I argue it's right on the front of the breast. So I don't love that at all. And ultimately, it was found that particular incision on the nipple has a higher risk of capsular contracture because you're going through the nipple. And we love nipples, but nipples are not the cleanest part of the body. And so, unfortunately, there's higher risk for some biofilm to get on that implant. And so my incisions, if it's a straight aug, are going to be underneath the breast crease, but they are tiny. If it's a small implant in the 200s, it's a 3 centimeter incision. And if it's anything bigger, it's a 4. We use a funnel to place it in. So it does not need to be large. That is, to me, probably one of my biggest pet peeves is seeing a large incision for any size implant. It's completely unnecessary. It creates increased healing time. It can disrupt the muscle. It disrupts that beautiful inframammary fold that is so important for support. So I'm like a stickler for only making the incision that you need and nothing more.
What can a patient expect their scars to look like the first couple weeks after breast augmentation?
I don't really want them looking at them, quite frankly. So, Val and I, we put it in a bandage over the incision. We use steri strips, which cover the incision, and we tell them to keep them on until we see them at 2 weeks. If they fall off, they fall off. But I don't want anybody looking at anything, But if they happen to see something and they're cleaning that area, it's going to be red. It's going to be a very obvious incision that you can see. My particular incision will have some sutures hanging out the sides. I don't like knots in that most superficial portion of the incision. So my patients will see these little whiskers coming out the sides. That are these clear? They look like pieces of floss. And then at 2 weeks, we take the bandage down for them, and if it's still there, and then we trim that suture. And then at that point, at 2 weeks, they're seeing a pretty well healed incision at that point. It should be just a very, very fine, thin line at that point.
And at that point, can they start using something on their scars?
Yeah. So there was a study done, and I ended up having to do like a grand rounds at Hopkins when I was a resident on what really works for scars. Mm-hmm. And there's all this fancy stuff out there. It is super simple. Anything that is 100% silicone is your answer. No Mederma, no like all these other crazy things that you like to put on you ultimately, once it becomes a scar, not when it's a fresh wound, you're going to want something that creates compression and some moisture and protection. And all three things are achieved by 100% silicone alone. So that can come in a gel, it can come in a strip, but that's it. Nothing else. Let the body do what it needs to do. And all you're doing when it comes to silicone is creating an environment that will ultimately aid your body to do what it already knows how to do, which is heal that wound. Start doing anything more than that, you'll start irritating it, and it actually makes it more difficult to heal.
Yeah, we're a huge fan of Silicone. I use that on my scars after my breast augmentation, and I can barely see my scars now.
Yeah, it's awesome.
I used it for about a year, and it did great.
Yeah, and that's the thing too. Like what you just said is so important because people think, like, when am I healed? But the truth is that even when we clear them for full activity, that scar is going to take 1.5 years to completely mature. Mm-hmm. And some patients, they are red for a while. Yeah. It's a bright red scar, and then they soften over time, and it just depends on the patient. I never promise an invisible scar, but certainly when treated well and treated right, it can be nearly imperceptible.
How long typically does breast augmentation take?
So it takes us about an hour. I never pride myself on being the fastest surgeon there is. You'll hear people who say that they do it in 20 minutes. That's fine. We do our surgeries a different way than some, I would say, in the sense that when our patients choose their size, they choose a range. So some surgeons will do the sizing and make you choose your size. And that day, all they do is put in that implant. There's no sizers. They clean out the pocket, they create the pocket, they slide in the implant, they close it, they're done. And that's fine, and that works for certain practices. I like a little bit of an artistic license to give the patient exactly what they want, and sometimes they can't know that until I'm in there in their body putting incisors. So we do a lot of really discovering what the patient wants before we go back. One of those ways, of course, is by them doing their sizing, but we also ask them for some pictures, some ideas of what they're really looking for, just to see if we're kind of seeing the same thing. We show them patients that have already had the procedure done by us, and it gives them an idea as to what things will look like. And then with all that information, we go into the OR with a range of implants, usually 2 to 3 different choices. And they typically will tell us what they liked when they did their sizing, but then it allows us as a team to place the sizers and really see if we're giving them the exact look that they're looking for. For instance, if a patient picks a certain size and it goes in, and Val and I see that sizer go in, and we're like, what happened to the implant? It's gone. It filled a lot less than we thought. We have the artistic license to be able to put in a bigger size. And that certainly has happened to us. I mean, we've definitely had experiences where a patient picks a size and it's way too big for them. I can't even close the incision, and we have to go down. And because we've had that conversation with the patient, there's never any concern about that decision. They know that we're going to do the best thing we can for them. And because we've had that conversation, it really 100% of the time works out that they're satisfied because we've been able to do that for them.
Now, during consults, if one of their main complaints is sagging, can they get away with doing a lift without the incisions and just using the implant?
So, yes. The answer is yes with a question mark. Yes? So it depends because let's go back to that like whole breast footprint situation, right? So the breast footprint is measured based on where their nipple to notch is, and then kind of the base width, and then how low their nipple is compared to their fold, and then where's their nipple according to the chest. Some of that is natural. Some of it happens with just time or babies or pregnancy or weight gain. And so at some point, there is a more aesthetically pleasing place that your nipple should be. But that's a range. So it's somewhere between 19 and 23 centimeters from the sternal notch is where your nipple should be. So that gives you a little bit of leeway, right? So let's say your perfect location, if once I measure you, would be 19, and your nipple is sitting at 21. Well, it's not at 26 looking at the ground. So no, you don't need a lift. And if you put a little volume in behind that nipple, it is going to naturally lift a little bit. What's not going to happen is your breast footprint isn't going to lift. That requires some surgery. But if it just needs a little oomph, an implant alone can absolutely do that. And I think it can look very, very natural. I probably offer that more now, interestingly, than I did when I first started out. I think there's two reasons. One, I think I offer that more now because women are looking for a more natural, kind of soft, voluptuous look more than they were before. I think they're okay with that look. Everyone's kind of gotten out of that like high and tight look. And I think I offer it more now because I've kind of gone through it all myself, like going through pregnancy and then breastfeeding and watching how my breasts evolved. And I certainly have drooped over time, but I still think they look very natural and beautiful. So I don't think that every patient, when they walk in whose nipples have dropped a little bit, need to be committed to a big, crazy breast lift.
It's great that they have the option if they wanted to, though.
Yeah, and I think it depends on what they say. Like I ask patients to use their adjectives, right? If they keep saying perky, they're going to need a lift, right?
Right. Yep.
Like it's got to jive with what they're looking for. Like they could not want to lift, but want to have this high and tight breast. And obviously I'm not a magician. So just depends on, if we can meet their expectations.
As far as recovery, how long are you asking your patients to lay low for?
So if it is a straight breast augmentation, I do my implants above the muscle, and for almost the vast majority. And so I do find that recovery can be quicker. So our patients are asked to really limit their major physical activity for 4 weeks. They can walk immediately, so I don't care how long they walk. I just don't want them having major physical activity, running around, lifting heavy weights for 4 weeks. But at 4 weeks, they literally go back to doing whatever they want. I do think it's important. You'll see a lot out there about these like flash recovery surgeries and whatnot. I think it's total BS. I think you need to give your body the time it needs. And I don't just think that. I've seen it where patients at 2 weeks feel so great and ignore our rules and come back here with hematomas, meaning that they bled into their pocket. I've seen it time and time again. And it's why we tell patients to sit still.
What kind of complications does someone need to be aware of with breast augmentation?
Well, what we just talked about, I do feel very strongly if you follow our instructions, you're going to do well. And so complications can arise even when you are perfect. You're the perfect patient, but you're definitely going to minimize your complications if you follow the rules. And Val, really, really goes hard at educating our patients before surgery to know what things to look out for and the things that they should avoid. But even when all that stuff happens, complications can happen. You certainly can have a bleed in that pocket. And if that happens, you have to come back to the operating room. We have to wash it out and put the implant back in. Complications can happen the entire life of the implant. So you can have a risk for rupture. These days, the FDA suggests that patients get a ultrasound or MRI at 5 years after they get an implant placed, and then every 2 to 3 years after that to make sure that it's not ruptured. So that's a really good way to monitor that. Another complication that can happen is something called capsular contracture, and it's just simple. We make scar tissue around everything, and so if the body makes too much scar tissue, it can get very hard around the implant. It's not necessarily dangerous or anything like that for the patient, but it certainly can start to look funny. The implant can kind of look funny and deformed. It can feel hard. It can get sore, and if that happens, we have to take out that scar tissue and put a fresh implant in. And I would say that one in particular it's a low risk, but it's still the most common complication. And we definitely saw an uptick of that with COVID. I don't think the studies are out there yet to prove that, but certainly in the community, we saw more capsular contracture during the pandemic. And it makes sense because we knew before the pandemic that viruses or any kind of infections can create a biofilm around the implants that creates an immune response and can cause some of that scarring. So that's a way that it can happen. There are things like physical, car accidents can cause it. But ultimately, it's not something that I want our patients to worry about, but be aware of, because, again, at any point of the life of the implant, the capsular contracture can occur. And if it does, there's an answer for it. But the sooner we know that it's happening, the better the treatments are.
As far as replacement, do you have a suggested time that you recommend that a patient replaces their implants?
I don't. I get it asked all the time, though. They used to say a decade, so every 10 years. I don't even know where they got that number. I think they made it up. And I say they, and whenever I say they, I'm talking about like before I was in practice. That was kind of what was said. And now I don't know what to say, except I think that you should just continue your regular monitoring and follow up with those ultrasounds. And if the implants are feeling fine and doing fine and you're not having any issues with it, I really struggle with telling patients they have to replace them. I will say if an implant's 15 years old, something like that, and we're already going in to do something else, I will mention it to them. I'll say, hey, there's at some point you're going to need something done. We're already going in for blank. Why don't we just something to think about. We could exchange the implants while we're in there. But doesn't have to happen. They definitely don't have to. So.
It's like, if it ain't broke, don't fix it.
Yeah, I would say. Yeah.
As far as having kids after breast augmentation, have you heard anything about affecting breastfeeding, or do you have a lot of patients that come in and will ask you, should I wait before having a breast augmentation if I plan on having children?
Yeah, so that's actually a question I ask every patient. If they have children, are they done having children? If they haven't had children yet, are they planning on it? I think ultimately it just helps us guide them as to what the best time frame is for them to have an augmentation. You absolutely can breastfeed with an implant. I can speak from personal experience. So can Val.
Me too.
Yeah. We had no problem feeding our children with implants. So I usually say to patients that the ducts don't, as far as we know, and from past experiences, the ducts are not affected by that implant. And so if a patient could produce before the implant, they'll be able to produce after. That's a hard thing for women who are really young and have never tried, right? So I always say if you've never tried breastfeeding, we don't know if you're one of the 30% who may not be able to breastfeed, because that's a real number out there. We don't talk about that in the breastfeeding world, but there are women who just naturally can't breastfeed productively. And so I always talk about that. I think it's really important to talk about that with every patient, that if you haven't breastfed and you're about to undergo breast augmentation, if you can't afterwards, I don't want them regretting their implants and feeling like they did this to themselves, because it could very well be that they never were going to be a producer. So we talk about that. The studies will show that there is silicone in the breast milk, there is silicone in the bloodstream, but the levels are so low that they are in no way at a level that would be damaging to the baby or the mom. That study has been done many, many, many times. And we're not talking about this today, but this does differ when it comes to doing a breast lift. The risk changes once you start changing the topography of the breast. Then breastfeeding becomes a little bit more complicated. Not necessarily 100%, but it can.
Bodies do some amazing things.
It's crazy.
It's wild. Coolest thing, though. How can someone schedule a consult with you?
So, there's multiple ways. So if you want to come and hang out with us now that you've met Val and I, and you love this vibe, you can email info@jevps.com. And that will go right to our director of our practice, Danielle. She will get right in there. You also can go to our website, JEV Plastic Surgery, and you can click on the link to have a consultation. You also can message us on Instagram, either Dr. Dr. Carrie Houssock or JEV Plastic Surgery, and you can call 410-484-8860. Come see us.
Danielle's your girl.
Danielle's our girl.
She also talks about the financial part of it. We don't do any money. We just take care of you.
Yeah, please don't ask me. I mean, people are always going to want to know. So, like, how much do augments cost? Augments are a range. They're somewhere between $7,000 and $10,000. And I know that sounds crazy, but it is a range, because do you need a lift with it? Do you need an implant? Do you want silicone? Do you want saline? It all depends. So there is a range, but Danielle can give you a better number if you call. Perfectly Imperfect is the Authentically Human podcast navigating the realities of aesthetic medicine. JEV Plastic Surgery is located in Owings Mills, Maryland. To learn more about us, go to jevplasticsurgery.com or follow us on Instagram at Dr. Carrie Houssock, spelled DrCareHoussock, or just look in the show notes for links. If you enjoyed this episode, please share it and subscribe to Perfectly Imperfect on YouTube, Apple Podcasts, Spotify, or wherever you like to listen to podcasts.